Lindsay Hopper.
Present by video. Good morning.
Lindsay Shirahama.
I'm joining by video.
Thank you. Holly Sorensen indicated, she just emailed me, she sends her regrets for not being able to join today. Andrew Stolfi.
Morning, everyone. Joining by video.
Sukinai. Drew Tarab also sent me a note that he was delayed. His flight back was delayed. So thank you, Drew, for your advance heads up, and he will be absent today. Nishoba Temperley.
I'm here by video, thank you.
And we also have, so that completes the roster for the HIMAC today. We also have our staff in the room. Victor Garcia.
Present in person.
He is our Operations Development Specialist, and Don Shaw is our Office Support Coordinator. Back to you, Craig.
Great. Well, I think everybody can see on the screen that we have our meeting protocols and requests. We went through this at the last meeting. Just as a reminder to everybody that the marketplace is committed to a safe and inclusive meetings and for all attendees, and that we respect all differences of opinions. And please do speak up if you have any questions. There are no bad or silly questions. And we do want to hear all perspectives, and we welcome everybody to speak. And of course, if you see anything that you want to talk to Chicky about, please report that back to her. Go to the next slide. And then some other protocols. If you're on doing this remotely, please be on camera as often as you are comfortable with. If you have any questions and you are, again, on camera, please raise your hand. And there is the ability to turn on live captions if you need to. So that's that. And our first order of business this morning is an approval of the meeting minutes. I believe that Dawn sent those out in May initially, and then we sent them back out with this packet. So hopefully everybody's had a chance to review those and provide comment. So any
I'd like to move to approve.
Great.
Second.
Quick order of business. So everyone in favor, please, how should we do that?
Folks in the room. So we have first motion by Ines, second by Paul, and sorry, no, by Ron. And then those in favor, please say aye in the room first.
Aye.
Aye.
Thank you. And those in the virtual room.
Aye.
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 All right, we are moving right along. What if we have Stephanie ready for us? We could get started a little bit early.
We're actually, so Stephanie had requested to be moved a little bit further down the agenda, so we will get started with Katie first.
Good morning, everyone. I'm Katie Button. I'm a plan management analyst here at the Oregon Health Insurance Marketplace, and today we're going to learn about plan management. Next slide, please. So plan management is responsible for plan certification, carrier oversight, and then public policy work relating to carriers and plan offerings. And I'd like to give a shout out to my friends at the Division of Financial Regulation, because I could not do what I do without their partnership. And we're really fortunate to have them be willing to work with us so that we can make sure that we have the best possible plans here in Oregon. As we go through this presentation, I tend to be a really fast talker, and I will try to slow it down. But if you have questions, please just shout them out. It doesn't bother me at all to be interrupted. Next slide, please. So let's talk about some basics about qualified health plans, make sure we're all on the same page. So a qualified health plan is often called a QHP. They're ACA compliant, which means they cover the 10 essential health benefits. They have limits on things like cost sharing, like you can't have a $50,000 deductible, and they fall into one of 4 plan tiers: catastrophic, bronze, silver, or gold. There is another plan tier, platinum. Carriers can offer platinum plans if they wish. We don't currently have any platinum plans in the individual market, but we do have those in the small group market. QHPs are offered in the individual and small group markets, and then they must be certified by the marketplace. Next slide, please. So here's a slide that kind of shows the relationship between premiums and cost sharing. So generally, the lower tiers have lower premiums but higher cost sharing, and then as you move up, the premiums decrease, but the premiums increase. I clearly have not had enough coffee this morning. The premiums increase and the cost sharing decreases. So depending on the amount of services you use, the types of services you use, and whether or not you use any prescription drugs, you may find that one of the tiers is better for you because it offers the best value on both premium and cost sharing. Next slide, please. So CSR plans or cost sharing reduction plans are something that's only available in the individual market, and it's only available on exchange. And so this is our 2023 standard silver plan. And so you can see how the cost share reductions work. And so I like to think of them as like a discount. So if you look at the bottom row, the physician visit, you can see that on the base level plan, that's $40. But on the highest cost sharing plan all the way to the right, it's $10. The physician is still getting the whole $40. The carrier makes up the $30 in premiums, but the folks that are enrolled in that highest cost sharing variant are really getting a good deal. And so that's why we like to encourage folks to enroll in those plans when possible, because the amount that you save on the cost sharing is a real benefit. And it's not always apparent, because when you're looking at healthcare.gov, you're only seeing the cost share variant that's relative to you. And so I think slides like this are really great to show the examples of like how really those plans increase in benefit. Next slide, please. Then there's a second set of CSR plans. We normally, when we say CSR plans, we're talking about the silver plans, but there is a second set that's for members of federally recognized tribes. These are available at all metal tiers, and there's two sets. The first set is for folks with incomes of under 300% federal poverty level, and those folks are eligible for zero cost sharing on all services. So all covered services are completely no cost sharing for those folks. And then folks who have incomes of over 300% are eligible for zero cost sharing on all services received from tribal providers. So that could be like Indian health services, tribal clinics, any provider that's considered a tribal provider, the carrier will pay all of the services. Next slide, please. Tax credits. We love tax credits. So this slide kind of shows how tax credits are calculated. And so there's an expected premium contribution, and you can see those amounts below. These are the current premium contributions with the American Rescue Plan Act subsidies. And so every person, it's just assigned by income. There's an amount that's considered affordable. And so then that amount is subtracted from the cost of the second lowest cost silver plan, and what's left over is the tax credit. Next slide, please. So this slide really shows, it's an actual real world example of how tax credits work. So this is for a person who lives in Eastern Oregon, and their amount that's considered affordable is $19 a month. And so then the second lowest cost silver plan is $413. So you subtract 19 from 413, you get $394, and that's your tax credit. Then on the bottom, you can see how that tax credit applies across different plans. So you can take your tax credit, you can use it on any plan. And so in this scenario, the person would be eligible for a $1 bronze plan, a $19 silver plan, or an $89 gold plan. And there are many more plans per tier. So as you look at different plans, your tax credit would change, or your amount of premium owed would change, but the tax credit remains the same. Next slide, please. We also have dental plans. We don't often talk about dental plans. Usually when we're talking about plans on the exchange, we're talking about medical plans, but we do offer dental plans. And for folks who have leftover tax credit and have children, you can use the tax credits on the pediatric dental benefits of a dental plan, because those are part of the essential health benefits. And I have seen people do it. It's an advanced exchange maneuver, but it does happen. Next slide, please. So then we're going to talk about plan certification. So we start with a request for applications, and that's a little different than a request for proposals, because we take everybody who can meet the requirements of our RFA. So we release that every 2 years. And the idea of that is that it helps create market stability by not having to change, not allowing new carriers to just enter the exchange every year if they wish to. So we do it every 2 years. The carriers complete a questionnaire and an attestation. And normally I don't have returning carriers complete the questionnaire, but every so often we decide we want to ask new questions. And so I will put those on the questionnaire. Otherwise, most of the time, since we haven't had any new carriers in a while, everyone does the attestation. And the attestation is them saying that, yes, they will do all of the things that they have to do in order to offer plans on the exchange. And so then carriers that submit a completed application are approved to participate on the exchange. So currently we have 3 medical carriers, 3 dental carriers, and 3 carriers that offer both medical and dental. Next slide, please. Then we get into plan review. So this again is where I work with my friends at DFR, and we'll sit down as early in the year as we can, and we'll look at any new federal requirements, any new state requirements. We'll talk about things that happened the prior year and see where there are things that we felt could have gone more smoothly, where there are things that we feel like the carriers should change to make things better. and we'll set the requirements. And then DFR very kindly includes all of the exchange requirements, and they will post them on their site. So the carriers just have one spot to go, and they know what all they need to do. So for 2023, we have 20 individual dental plans filed. We have 77 individual medical plans, which then become 309 plans with the cost sharing reduction variance I mentioned earlier. And then, so then DFR and I do what I like to call a concurrent and coordinated review. So they review the rates, and Tasha Sizemore is going to come on after me, and she'll talk to you about rate review at DFR. And DFR reviews the forms, which are like the contract documents the carriers actually sign with their subscribers. They review network adequacy, and they review the drug formularies. Next slide, please. Then I come in and I review the essential community provider requirement and make sure carriers are meeting that. I look at the plan crosswalks and make sure that if carriers are discontinuing plans, that the plans they've chosen to crosswalk people into make the most sense. There's an attestation that carriers have to submit to CMS that I make sure is in there. I review the quality improvement strategies. I review their URL templates to make sure that all of the URLs for all of the things are in there. And then I review their accreditation to make sure that they're up to date on that. And then together, DFR and I review the plans themselves. And so first we look at the standard plans, and those are very spelled out. So we just go through and make sure that all of the amounts are correct as they're supposed to. And then we review the rest of the plans. And so DFR will look at them and make sure that they're meeting all the state and federal requirements. And then I look at them. So these are just giant Excel templates with columns to the end of time. And I'll just scroll across, and then I can see outliers. So if a plan is everything is subject to deductible except preventive care, and then I see X-ray is not subject to deductible, that's probably a mistake. And so I'll go back and say, hey, was this a mistake? And so then that way I can help the carriers find those little things that after you've looked at something 100 times, you can't see anymore. And that seems to be working well for us. Next slide, please. So then once the carriers have submitted their plans and we've looked at them and we feel like they're pretty good, then we transmit them to healthcare.gov. And then I put them on the window shopping tool. And then because the marketplace is kind of the entity that controls the plan data, if there are ambiguities, we'll be the decision maker on what should happen. So for example, in Oregon, habilitative services, carriers are required to cover those both in an inpatient setting and an outpatient setting, but healthcare.gov only has one place to display them. And so we talked about it and we decided that it made more sense to display the outpatient costs because that's how most people access them. So that's an example of when we stepped in and said, they should file it this way because this is how it's displayed. And then after DFR approves the plans, after I approve the plans, after the carriers have looked at their plans and all of the plan displays and said, yes, everything is good to go, then I certify the plans. And this year will be the 10th plan certification, which is kind of just mind-boggling to me. Next slide, please. So here's a quick timeline of how it works. Again, in the odd years, we do the RFA. We adopt the new requirements. Most of the time we're waiting for CMS. So we try to do it as close to the beginning of the year as we can, but sometimes it has to get pushed later. Then we design the standard plans. The plans are filed in May. In May through August, we do this iterative review and correction process. The rates are approved and the plans are approved in August. We sign a contract with the carriers and then plans are certified October 1st. Next slide, please. Policy work is actually one of my favorite parts of my job. And our SBMFP status actually lets us maintain full control over plan management. The other states recommend plans for certification, but they don't actually maintain full control. And I maintain control. I certify the plans. I am the one who tells CMS if they're okay and ready to go. And we think that that's beneficial because we feel like in Oregon, we know our folks best and we're the most appropriate entity to make those kinds of decisions. And then we also use our knowledge to leverage plan requirements to ensure that we have quality coverage available. And we're really fortunate in Oregon to have a strong insurance market. We have a bunch of domiciled carriers and a bunch of carriers who've been here a really long time. And I think that really shows in the amount of carriers that we have available and the plans that we can offer to folks. Next slide, please. So another thing that we do in Oregon, and I think we do it well, and I don't think that we always get the credit we deserve for this, but our standard plans, we work really hard to make sure that those are really good for folks. So DFR designs the standard bronze and the standard silver base variant, and then I do the cost share reduction variants of the silver, and I do the standard gold. And we've worked really hard to make sure that the standard plans are like a safety net for folks. Like they're available from all the carriers everywhere, and we can ensure that every person has access to the things that we think are important. And so, for example, some of the things that we've done with the standard plans is that on all 3 standard plans, all of the office visits, all of the urgent care visits, and generic drugs are always ahead of deductible. that means that no matter what that deductible is, people don't have to meet it to access those services. And we've also made sure that more types of providers are covered under the PCP charge, which is lower. So things like speech therapy, physical therapy, all those kinds of habilitative and rehabilitative services and behavioral health are all at the PCP charge. And we've done this to make sure that folks can access those services, because we know that it doesn't matter if you can't access your care, it doesn't matter that you're covered. So we want to make sure that folks can actually access the care they need. Next slide, please. Another thing we've done is we've done our own window shopping tool, which I have demonstrated for this group several times. You can find it at oregonhealthcare.gov/window-shop. And we decided that we should do our own plan display because there was a lot of things that healthcare.gov was not showing consumers that we felt were important. And so we actually display all of the benefits available in our plans to consumers. And then it enabled us to do additional things like add telehealth, which we were able to do right at the beginning of the pandemic. And so when folks were enrolling in plans for 2021, they could see that telehealth benefit on our site. It also allows us to make quick changes. Again, when the pandemic came, we were able to implement the pandemic unemployment assistance calculation, which off-ramped folks to Medicaid faster. And then we've been able to load the increased subsidies under the American Rescue Plan Act. And we're currently working on updating a family glitch calculation. And we'll hopefully have some sort of calculator on our site that will allow folks to come in and see under the new regulations what they can be eligible for. Next slide, please.
Katie, can I ask a quick question before you move on to the next slide?
Of course.
For the window shopping tool, does it also provide information about providers and who's in network and who's out of network?
Yes, we do. This year, we have got providers and hospitals. So not all facilities, but we do have hospitals. And one of the things that's hard about healthcare.gov is that they don't do a great job of cleaning the data, especially on facilities. And so we've tried to clean that up a little bit for the hospitals. So hopefully folks are seeing better information on our site when they look for providers and hospitals that are in network.
Great, thank you.
Next slide, please. So carrier oversight is the last part of my job. So most of that is just making sure that carriers have done all the things that they need to do. There are some separate things carriers file directly with CMS that I make sure they have before I can certify their plans. And then I often act as a go-between when there are issues with the carriers and CMS. And sometimes that's just the carriers trying to do something that they're supposed to do. They're running into an issue, a technological issue, and they can't get anything. And so I will go through my side because I have a different contact and see if we can push it that way. Sometimes CMS forgets that we are an SBMFP and will send out notices to carriers asking for things that really aren't appropriate. And then I will remind them that they should be coming to me for those things. And then because I have a good relationship with so many folks at the carriers, when we have complex consumer issues, I often will help with those. So for an example, a person had something go wrong with their healthcare.gov plan, their tax credits went away, they can't figure it out. They've called healthcare.gov 100 times, they can't figure it out. I will work with the carrier to see what did the carrier get from healthcare.gov, what's showing on their end, and we'll see if we can work it out a different way so we can resolve that for the consumer. And that is the end of my presentation. I'm happy to take any additional questions.
Questions? Are there any questions for Katie?
I'll ask one more.
Please.
You had mentioned that we don't carriers don't offer platinum plans in Oregon. Do we know why that is?
They had very little uptake, and so it's not easy for carriers to file all of the plan documents. And so since there just wasn't very much uptake, then that's one of the things I think is really great about our carriers is that they will try things and then they'll kind of see what is attracting coverage and what's not. And when things obviously aren't that popular, then they'll drop them off. And so that helps our consumers have meaningful choice, but not too much choice. And I did forget that there is a coverage map at the end. So this is our coverage map for 2023. You can see that Lincoln and Deschutes have 4 carriers. Most of the counties have 5, and there are a few that have 6.
Great. Any other questions for Katie? If not, I have one for you, Katie. This is Craig. I was thinking about when you look at the standard plans, you mentioned that you take into consideration, it seems some discretionary considerations just for the consumer's perspective. How are you getting feedback on that, and how do you feed that into when you look at plans?
So GFR does do a rulemaking for the gold, or excuse me, the bronze and the base level silver. So I attend those and I will listen to hear if there are anything coming up. Otherwise, it's mostly just if we're getting complaints about things, if we're getting questions about things, we'll reach out to our community partners and our agents. It's just I'm constantly taking feedback from things. I will read, you know, articles and things about national coverage trends and, you know, what things are better for consumers. And mostly it's just, I've done this for a long time and I've kind of seen how plans have shifted over time. And so one of the things that I think about is if I'm making a change to a benefit because I have to make it meet the actuarial value calculator, are there changes I can make that impact everyone positively? Are there changes that might be negative but only impact some of the enrollees versus making changes that might negatively impact all the enrollees? And so it's just really kind of all of those things. I'm just constantly taking in any feedback that I get to put back out.
Yeah, I appreciate that. And I think that's maybe underappreciated how much you look at those things to make sure the consumers are getting the most benefit out of that. And having worked with you for over 10 years, I will say you are very helpful and a consistent voice on behalf of the marketplace. So we appreciate your partnership with the carriers. Ines, you have a question?
This is Ines Kemper. I do have a question. Have you ever considered doing something like allowing consumers to shop apples to apples oranges? So specifically, so if a consumer has no prescription needs, but does regularly go to a physician for something, and they want to see which of the metals would be most appropriate for them. It's, I mean, being in that position, I find it very difficult to figure out how to choose because that information is not obvious. So sort of like, you know, it's almost like a matchmaking thing, like a, you know, dating site call, for example, where it's like, oh, I don't need prescription, I do need this, I do need that, you know, what is in the end, what's the cheapest plan for me?
So on our window shopping site and on healthcare.gov, both sites you can put in your provider, and so you can see, and you can put in drugs. I think our window shopping tool does drugs better for folks who do take drugs because it will show you the actual cost sharing tier that your drug would be in. And so there are ways to do it. I agree, it's not always super easy, and that's why we always recommend that you work with an agent or a community partner if you have questions, because they are the person best suited to sit down with you and really explain your options to you, and they can really help you make decisions among those plans.
Okay, thank you.
That's a good question. Any other questions for Katie? You have an opportunity to give her feedback, so don't want to miss that. Okay, thank you very much for that, Katie. I think next we will have Tasha Sizemore give us an update on the rate setting process for 2023.
Thanks, thank you so much. I don't have slides because rates are not finalized, so apologies, but I'll be coming back and we can do this again once they're finalized and I'll have slides for folks. So for those who don't know me, my name is Tasha Sizemore. I'm the Life and Health Program Manager for the division. Today we're here to talk about rates, but I'll just tell you a little bit about everything my team does. So aside from managing the actuaries that work on health products, I also supervise the team of individuals who reviews the forms and the binders on our side, and we work closely with Katie to take a look at those and catch any big issues in the binders when they come through. My team also includes market conduct analysts that look at the product when it's out there in the market to make sure that it is performing how the insurer said it would and that we're not having any major consumer or provider issues. But this time of year, my focus is on establishing rates for the upcoming plan year. And so right now we're sort of mid-process. We changed our rate review timeline just a little bit to move us off of having hearings over the 4th of July holiday, which was always really difficult to schedule around. So our rate review hearings are going to be next week. And the actuaries are actually hard at work this morning getting ready to post the preliminary rate decisions that will be going out to insurers that will be part of our discussion next week. So let's talk a little bit about the things that the actuaries looked at with rates in the individual and small group market. So first of all, the individual and small group market continues to show stability. I know Stephanie Keenan is next, and so she's going to talk a little bit about the challenges probably with getting the American Rescue Plan provisions renewed. However, we are still seeing a lot of stability in our markets. However, 2021 claims are coming in higher than 2020. And that's probably just a little bit of rebound from a couple of years of COVID. So that is what we're seeing there. For 2023, we're not going to see any carriers leave the market, and we also don't have any new carriers. So it's just the group of carriers that we've seen in the past. Hold on just a second. My kid came in and said, my husband needs a Band-Aid. Hold on just a second. Okay. So apologies about that. So we have no carriers coming into the no new carriers or no carriers exiting any of our markets. So we're going to see pretty much the same stability. So rate changes on average are going to follow the medical trend. And so we're going to talk a little bit about what we're seeing with trend in just a second. Legislative, we also figured in legislative changes for 2023, including, as I mentioned, as I alluded to earlier, changes in the American Rescue Plan, changes in the subsidy, and I know that there was a presentation, or there's going to be a presentation later today on the bridge plan work. So those are all things that we considered. We also looked at Senate Bill 889 as part of the healthcare cost growth benchmark. And then just another thing to note, CMS did change the AVs just a little bit for the rates for 2023. And so we had to consider those changes as well. So once again, the rates are not finalized, but for the individual market, we're seeing a range of rate increases from 2.3% on the low end to 12.6% on the high end. And then on the small group market, we are seeing rate changes on the low end, just about 3.5% to the high end of 10%. So there are going to be some changes. However, these, for the most part, are single-digit rate increases, which is really nice to be able to carry that forward another year. Let me just see if there's anything else that I want to say. So as I mentioned, we also looked at medical trend and cost growth. This information, we'll be sharing information, I guess, with the cost growth task force about what we're seeing in the rates and what carriers are sharing with us. However, there are we are seeing trend in some cases and trend exceed the 3.4% that is in the cost growth benchmark. So, and inflation and everything else is playing into that a certain amount. So that is the kind of basic on rates for 2023. Any questions on rates or plans? And then, like I said, I'll come back once the rates are finalized and do an official presentation and give you guys handouts.
Are there any questions for Tasha? Anyone online or in the room? Well, Tasha, maybe this is maybe more of a comment than a question, but maybe you can give your opinion on this. But it is noticeable that the rates are higher than they have been for 2023 than maybe since 2019 in the individual market and 2020 in small group. And I think there was an article yesterday in the Oregonian, and we're seeing this nationally too. Across 13 states, the average is about 10%, about a 10% increase. So I'm sure that's getting the division's attention, but I don't know. Any comment about the review process because of the higher increases coming in this year?
So I think that that's part of what we will be talking about as part of the rate hearings next week. What we are seeing generally, as you mentioned, I think we discussed earlier this week when we met with the commissioner, that article or the kind of what's coming out in the discussion nationally. We are seeing kind of that rebound. Like I said, I don't think it is as bad as we anticipated. However, inflation is just absolutely ridiculous right now, and that's playing into it. And that was a large portion of our discussion. So duly noted that we're watching that. And I don't know if Commissioner Stolfi has anything he wants to add, not to put you on the spot, Commissioner. But we are still like formulating this, and we'll have more next week.
Yeah, and thanks, Tasha. And I want to be careful because we're right in the middle of the reviews and have the hearings coming up. But it's certainly something we noticed. Even before we got our filings, I was hearing from other states and other commissioners about what they were seeing and kind of expecting. And, just the concern across the board that we were going to see much larger than compared to the last, 2-3 years increases. And that we are seeing that in some states. I think, we'd love to see every year rate increases that are, around medical trend or lower, and we'd love to see that. Of course, a lot of us participate in the cost growth benchmark work, where we're trying to keep this growth over from year to year at a certain percent and lower. And so I always want to see the rate increases in the very low single digits, recognize that there was a lot more usage last year than in 2020. There were some carriers with underwriting losses last year compared to prior years because of that. And we've seen provider contracts. We don't review provider contracts, but we hear about them and how there have been some significant changes in those over the last year and two, which all influences the rates that are paid. So, a lot more will come out during the hearings and afterwards, but it's not as great as we would hoped, but not totally surprising either.
I appreciate the comments. Tasha.
Yeah, and I would just circle back to and add on to something Commissioner alluded to there. The increased utilization in the last couple of years and the what is in provider contracts. So we have seen increased utilization. COVID is not going away, and that probably has some to do with it, but also just pent up demand from folks putting off normal procedures. The other piece of this is the cost growth benchmark piece. And as the commissioner mentioned, we're going to be talking a little bit about this at the rate hearings next week. Highly encourage you guys to attend if that's something you're interested in. However, with the cost growth benchmark, that is kind of, we're in the early stages of implementing that, and that is influencing behavior from different sectors in the healthcare field who are preparing for that. And so I do feel like there's some front loading going on in terms of cost. So once again, a lot of this will be discussed at the hearings next week. If you have not been to a hearing in a couple of years, they have improved just a little bit, if I should say so myself. We're having the insurers prepare a slide deck now so that they can share information on less of an actuarial level and more of a consumer facing level. So if that's something that interests you, please attend. And then of course those are recorded and can be viewed later. And like I said, we're also having them do PowerPoints so we can get those up and people can look at them after. And each insurer's PowerPoint should go into a little bit of details about the factors that they considered individually when setting their rates or when requesting their rates. So please attend next week if that's something that interests you. Craig?
Great, thank you. I think the whole way that we approach rate setting in Oregon is pretty unique. It's a very transparent process. These public hearings are meant to be informational for consumers. And I guess well, we still have you, and we have community partners in the room and agents. I'm curious from those perspectives, is there anything that you could hear from the insurance division that might be helpful when you're communicating this to your customers or the consumers out there? Is there anything that might be helpful?
Hey, this is Lindsay. I think that's a great question, Craig. Thanks for asking that. And I've been trying to thinking of this from my client perspective side. And I know that each year when I help clients enroll in their plans and renew their plans, the cost is a major factor. And the client community that I've always worked with is a much lower income community. Like basically everyone's under 300%. And seeing the rates increase even that 3% is a significant financial burden for everybody. And so my concern is that we're going to see more people opting out of insurance just because there's that 3% to 10% increase in the plan that they had, or they'll let their plans roll over and they'll go, oh my gosh, my premium is so much higher than it was last year. I didn't realize it. And I know that letters go out and like that is communicated, but you know how much people read their mail. So I'm like, that's one of the concerns I kind of see down the pipeline. But I don't know what insurance could do to ease that tension, because at the same time, yes, inflation's high. However, people's wages are not going up.
Thanks, Lindsay. Yeah, definitely understand that the sticker shock either during enrollment or, you know, when that first premium bill comes through in January. That is one of the reasons why I asked insurers to start putting together those PowerPoints, because that's something we can put up on our website, and that as agents and community partners, you can use those and refer back to those, and it's not as boring as a recorded video. No offense to the actuaries from all of the teams, but rate review is not very it's not very fun for a consumer. So hopefully those PowerPoints will help just a little bit. It is something I'm very cognizant of though, because rate review happens basically 4 to 6 months in advance of them actually seeing the cost and experiencing it. And so tying this together a little bit more for them, for the average consumer, is really important to me. Like you said, we can't really deal with inflation, you know, single-handedly, and I can't increase wages for everybody. So hopefully the more transparency it will help, like I said, agents and community partners when it comes to that time of the year.
I think you said something that's pretty important about somebody who just lets their plan roll over and then gets a big sticker shock. So maybe it's knowing ahead of time that there are larger increases we'll encourage people to shop around and not have it happen to them. So there are options, fortunately. So probably just a more active year this year, fortunately for some of our agents. Busy. Okay, any other questions or comments? Great, thank you, Tasha.
Thank you, everybody. Be back in a couple of months.
All right.
Bye.
So I see we have Stephanie. We're a little bit ahead of time, but I think if you're ready to go, Stephanie, we'd love to hear from you.
Sure, thank you. And I apologize for my voice. I have a cold. And yes, sometimes a cold really is a cold. So everybody's been shocked. I haven't had COVID, but I have a cold. So this is a really hectic time in DC between now and August 5th. Congress wants to recess August 5th or somewhere around there. They're trying to breathe life back into budget reconciliation. And I know some of you have not been present when I've explained reconciliation and all the machinations that have to go on. So I'm going to do a quick little primer. Budget reconciliation is essentially a process by which there's a budget resolution. The resolution contains reconciliation instructions. Those instructions go to the committees that are called authorizing committees. For example, Senate Finance Committee is an authorizing committee for Medicare, Medicaid, Social Security. The instructions say either cut spending by X or increase spending by Y, and the committees figure it out. Now, you have authorizing committees in the House as well. The equivalent of the Finance Committee in the Senate is the Ways and Means Committee in the House. They could come up with completely different plans, but still meet those financial goals. The real reason for doing reconciliation is because in the Senate, you need 60 votes to sneeze. So with reconciliation, you only need a simple majority. So you may remember the Build Back Better Act. That was reconciliation. It passed the House in November. It died in the Senate. So ever since then, the Senate has been trying to negotiate with Senator Manchin and Senator Sinema about what exactly they could get together. Manchin did not want the bill that came out of the House. That had a lot of goodies in it, including things like the extension of the tax credits that are important to the marketplaces, and a number of other really good healthcare items. Manchin has said, I will go along with a 2-year extension on the tax credits for the premium subsidies and the drug reform package. And that's it. Now, the way it's been presented in the press, it has been essentially that the Democratic leadership in the Senate has said, oh, goody. We know that President Biden has said, take it. Senator Schumer is still working on trying to get 3 years of tax credit extension, in large part because he and a number of other Democrats would like to put that extension out beyond the presidential race. Schumer is also dealing with a set of Democrats who are unhappy that Manchin won't go along with what is known as the Medicaid Gap, those solutions for those states that didn't increase their Medicaid programs. And a group of Democrats who are very unhappy that there's no tax provisions that Manchin will agree to. In particular, there's a group that's upset about the state and local taxes, SALT. And usually it's really kind of concentrated in the mid-Atlantic to around New York and Connecticut, people who have real high property taxes. Not to say others don't, but that's the group of senators that are most upset. So Schumer has to navigate to see if he can add the additional year of extension on the tax credits, and keep everybody together on the drug proposal. And I'll talk about that in a second. And they would like to add some COVID funding in there because the administration's now dipping into funding for the national stockpile. They've done that twice. So they're going to try to sneak in some COVID funding for vaccines and supplies. This is taking time to work out, but they are working on it rather hard. And if they can get it together, they could put it on the floor the first week of August and do it before they leave. And then that would mean it has to go back to the House to approve, or they have to have a conference committee. Most likely the House would approve it. One big hurdle before they can move forward, hopefully we have an answer today on this, is known as the bird bath. Now, the bird bath is a process. There's a rule called the Byrd Rule, named for Senator Byrd, who's no longer with us, that essentially said that anything in budget reconciliation has to affect federal spending, federal spending directly. It can either increase or decrease, but it has to be a direct spend. So if you have a provision that's budget neutral, it can't go on reconciliation. If you have a provision that does something indirectly, it depends. If somebody calls you on it, it can't go on reconciliation. So they have sent the drug reform package, which includes Medicare drug negotiations, to the parliamentarian of the Senate. And the parliamentarian and the Democrats and the Republicans are sitting there arguing line by line about what meets or does not meet the Byrd Rule. They are supposed to be finished sometime today. I suspect it will be late today. And there are some things in there that the Democrats are worried about may get tossed out. Before the package went to the parliamentarian, the Democrats did some tweaks on the drug reform package. The biggest one I think everybody's been interested in is that originally that package had a provision that capped insulin at $35. That was tossed out because it's too expensive. And insulin will be in the Medicare drug negotiation group of drugs to be negotiated over. So they kind of fix for one group, but not everybody. In fact, the leading Senate provision on that cost $23 billion, and the Congressional Budget Office figured out that it actually created a windfall for the manufacturers. So that was another reason to strike. So again, we're hopeful that at least 2 years, maybe 3, of the tax credit for premiums will get in this package and get done, at least almost done, get through the Senate by the end of the first week in August. Keep your fingers crossed. I've seen many pieces of legislation blow up and come back to life and blow up and come back to life. And this has been one of those that really has been a roller coaster. If you had asked me 2 weeks ago if we could do this before I left for recess, I would have told you no way. It was Senator Manchin essentially coming out and saying, okay, this is what I'll go along with. Senator Sinema, who has also been, well, shall we say, a Democrat with a different view, has told Senator Schumer she could go along with this. She's got no problems. So that means they can keep those Democrats together. One other issue I want to raise is appropriations, keeping the government funded. The House is farther ahead than the Senate in this, which is a good thing because appropriations are supposed to originate from the House. The House yesterday passed what is known as a minibus. That is 6 bills. Labor HHS was not on the minibus. That may be done when they come back in September. There are a few issues they're still trying to iron out, nothing major. It's just some things around the edges. But what they're trying to do this year is package them in groups and send them over to the Senate. Unfortunately, when they send them over to the Senate, they're going to sit there and die until September. Most likely, we will have to do a continuing resolution, a short resolution to fund the government. Because I don't think they'll have it all done by September 31st or October 1st, which is when we all turn into pumpkins for the fiscal year. In the Senate, they're still arguing over what are known as the top line numbers. What are the big top line numbers for every function of the government? And then you figure out the programs after you get the top line numbers. The issue is defense, and several very senior important members have different views of the defense number versus any other number. So that's still being argued with in the Senate. The last thing I want to mention, just so that you understand what's taking the oxygen out of the room in the House and Senate, there is a very important piece of legislation called Fda User Fees that needs to be passed before the end of September. This is how we partially fund the FDA. It's literally fees from drug and device companies and food companies to use the FDA. The House and Senate have slightly different views, not views that would be hard to work out, but some differing views. But it appears that in the Senate, Chairman Murray and the ranking member, Burr, aren't speaking to each other right now. And Burr got mad at being labeled the person who was holding things up and put in a very narrow, skinny bill and is saying, let's vote on that. Let's just go ahead. Let's just do a reauthorization and forget all the things we were trying to do. That has not made relationships work very well right now. So the problem is a lot of the people who are on appropriations are also working on the FDA user fee bill. So there's just not a lot of stuff moving very fast out of the Senate, except maybe reconciliation. On that, I'll end, and I'd be happy to take any of your questions. I've shocked you into silence.
Looks like we have a question from Lindsay. Go ahead.
Thank you. Lots of updates, understand many moving parts. We're going to talk a little bit more about silver loading this morning. Just curious how much that's come up in some of the conversations to date. Thank you.
That's a very good question. Senator Manchin, about a month ago, had said that he was not interested in doing anything on the tax credits unless they did something about the silver loading. Right now, no one knows the structure of the tax credits. They don't know if they're going to do something on silver loading or not. I think that is all part of the negotiations to get one more year in. It's been one of those mysteries, and I think the 3 or 4 staffers who really have to know what's going on are tired of saying, I don't know what's going on. But it is coming up in conversations a lot.
Thanks, Lindsay. Any other questions for Stephanie? Well, maybe I'll comment that last time we talked, I was concerned about the American Rescue Plan subsidies going forward. It seemed like there wasn't a vehicle for that to happen, but it sounds a lot more promising.
Yep.
At this point, so that's good news.
I think there are a lot of people, including Republicans, although they may not want to say it out loud, who really do want to see those go forward. They get what the disaster will be, and it would be just before the midterms, so it'd be not good for a lot of people. So sometimes self-interest helps move things along.
Great. I think with that, at this point, we're ahead of schedule. So we're going to do a 10-minute break so we can stay on schedule for public comment at 10:10. So that's
folks, sorry, before my mic decides to fly away from me, we're going to thank you, Stephanie, for your time today. We're going to take a 10-minute break, and we'll kind of we'll make sure. So please be back around 10:09. It's 9:58 right now. Please be back online on camera if you're a committee member at 10:09. Thanks, everyone. We'll see you shortly.
Good. Welcome back, everybody. This is Craig. And first, yeah. Great. Before we get to Director Allen, we're going to take a moment for public comment.
So we do not have anybody in the room for public comment. Do we have anybody in the virtual room who's here for public comment today?
Hearing none. Well, great. Thank you, everybody. We're at the point of our agenda where we're going to hear from Pat Allen. He is, of course, the director of the Oregon Health Authority, and people may know that the Health Insurance Marketplace Advisory Committee moved to the OHA recently, so now we're under Director Allen. And people who know Director Allen, he was formerly the director of DCBS, and he was had an instrumental role in helping the state get through the COVID pandemic, and has a lot of authority, and we're fortunate to have him this morning. So Director Allen, I'll hand it over to you.
Well, thanks, Greg, and thanks for the opportunity to be here. Some days I wonder how much authority I have versus accountability, which I know I have. But I'm really delighted to have the opportunity to welcome you all to the large family that is the Health Authority. You know, the Health Authority was formed about 10 years ago, and the general idea was to consolidate all of the state's purchasing and policymaking and regulatory authority around healthcare into one place. And I think especially with respect to purchasing, to be able to use that purchasing leverage to really drive the triple aim in the state, to get Oregonians better health care at lower costs, and to deliver health equity across all of that. Today, if you include the lives in the health insurance marketplace, OHA provides health insurance for about 40% of Oregonians, which really is a powerful platform to help us be able to deliver the promise of the triple aim and really be able to make meaningful changes. And so I'm really glad that the health insurance marketplace and this advisory committee are a part of that umbrella, because I think we can work together a lot more powerfully than we can working in separate silos. I think one of the most important things right now is that we've made some great gains over the course of the pandemic in getting people health insurance coverage. We've reduced the overall uninsurance rate in the state. We've reduced it dramatically for Black Oregonians. We've made progress in communities of color. We've been able to add to the Oregon Health Plan at the state's own 100% expense kids who are uninsured regardless of their citizenship status. And now recently we've begun rolling out the Healthier Oregon Plan, which expands that coverage to adults regardless of their citizenship status. And so we're really getting to a place where we can meaningfully deliver 100% universal access to health insurance. And of course, one of the things we've always known, but it was driven home for me, at least in the pandemic, was that insurance isn't the objective in and of itself. Insurance is a path to healthcare. And in particular in Oregon, it's a path to high quality, accessible primary care, because that connection to primary care is someone's connection to the healthcare system. And it becomes their connection to things like supports for effective quarantine and isolation in a pandemic. It becomes their connection to supports for testing, for vaccination. Now it increasingly becomes their connection to adequate reproductive health care. And so that notion of insurance is really the path, is really important to make sure that people get the care that they need so that they can have the health that they need. And I really appreciate this advisory committee's role going back over years in really keeping focused on that idea of how do we make sure people have got access to health. As we look forward to some of the things that are coming up, I think that really continues to be the driver as we think about what a lot of us have come to affectionately think of as the great unwinding. When the public health emergency finally ends, the things that have caused people to be added to the Oregon Health Plan and never really come off the health plan are going to go away. And so we're going to have to redetermine, and I think you've already heard a presentation on redeterminations. We're going to have to redetermine the eligibility of 1.4 million people. Huge body of work. And if left to our own devices and we didn't do anything else, and there are states that are taking this approach, probably 300,000 people would just simply lose their health insurance, and they would lose that access and connection to healthcare. And so the work that we're doing with the legislative work group and together with this advisory committee and others to figure out what are the plans that we can put in place to make sure that doesn't happen or to minimize it as much as we can are really important. Now we're getting to the hard work of, okay, we've got these people over here that we want to take care of, but doing that may have impact on other people elsewhere in the marketplace or in other plans. How do we minimize that so that we don't simply make one problem better by creating another problem? And that's really tough work that's going on right now, and I appreciate everyone's participation in that. Beyond that, I think in terms of priorities for the agency, the biggest number one priority has been our strategic goal since just before the pandemic, which is eliminating health inequity in Oregon by 2030. And we see health inequity manifest itself in a variety of ways. But again, that first place where those inequities do show up is in access to health insurance. Communities of color in the state have lower insured rates than white populations. We've made some progress on that in Medicaid during the pandemic, but we really still need to continue to think about how do we make sure that everyone in Oregon has got access to health insurance so they can get that access to care that they need. We also know, and we've learned a lot about that health equity goal during the pandemic. In some cases, some of us have had it really harshly demonstrated how far short we are of that goal. But I think most importantly, we've learned a lot about tools that work and what we need to do differently in our work to be able to achieve that goal. We've expressed health equity as at least a value for years and years, and nothing's really changed. And so clearly doing more of what we've been doing before isn't what's going to make a difference in closing that gap. We really do need to think about how to do our work differently. The agency's adopted a health equity definition that, among other things, talks about allocating and reallocating resources and power. And I think it's that reallocation of power that is really important and fundamental in trying to close the equity gap in the state. And what it really means is who's at the table and who decides. Who decides the issues that are important, who decides what we're going to focus on. And we need to make sure those tables are filled with people who are impacted by the decisions we make. And we're increasingly getting better and better at being able to do that. And I think that's just a critical element of being able to do this work. Maybe the last thing a couple of things to touch on. One is that we are moving forward with a proposal to the legislature to move off of the federal platform and move on to a state platform so we can be a full-blown state-based marketplace rather than the state-based marketplace with the dreaded FP in parentheses after our name. The political dynamic has changed a lot to make that possible, and a lot of that is through the really great work that this advisory committee has done to so successfully guide this program. If you had asked some legislators 2 or 3 years ago, well, and in fact 2 years ago, when the proposal was to move the marketplace into OHA, I kind of had to swear a blood oath that the platform wasn't a part of that deal. And that in no way would we consider doing a platform. And even over the 2 years since, dynamics have changed a lot. The market for platform technology has changed a lot, but I think trust in you all has really helped get us over the line that we can go back to the legislature now and make a proposal and not have the answer automatically be no, and in fact have it more likely than not be yes. And so I think that's really helpful. Last thing I'll touch on. The pandemic has been a tough experience for everyone on a whole bunch of levels, but I think we've learned a lot through the pandemic that's helped us be a better state, be a better state government, be a better organization. And I think one of the keys that we've learned is that I actually kind of at this point cringe at the name Oregon Health Authority. Because I think what we really learned is we're no more effective than our relationships at the local level on the ground. And whether that's with community-based organizations or local insurance agents or community groups, those kinds of things, that we really need to attend first to those relationships and think about those truly as partnerships in how we get our work done. Because we're not going to be able to be effective trying to, do everything from Salem or Portland or those kinds of things. And I think that's been a really valuable lesson to have driven home during the pandemic. So Chicky, let me stop there, and I don't know if you built in time for me to field questions, but I'm happy to do that.
Yes, we did. We filled it in time for like about 100 questions, Pat, for you.
Excellent.
Hey, thank you for your presentation today, Pat. You mentioned early on OHA provides, I think you said, insurance to 40% of Oregonians. Is that strictly the Medicaid population?
No, that's the Oregon Health Plan, which includes Medicaid and the non-Medicaid portions that are the Healthier Oregon Plan. That also includes employee benefits to all state employees and most education employees across the state, and the 140,000 lives through the marketplace.
Thank you for that clarification.
Mm-hmm. And I'm sorry, since you're all really, really, really small on my computer screen, if folks could let me know who they are when they talk, that'd be great.
Any other questions for Director Allen while we have him here?
Or random commentary. I'm open to that too.
Well, I'm always good for random commentary. So this is Craig. Thanks for your time this morning. And I appreciate also your comments about the moving to our own state-based platform. And I'm glad to hear that that's even changed within the last couple of years. And we'll get to it later on the agenda, but when we do talk about the bridge program, it's becoming clearer that having that flexibility within the state to do programs that are tailored to what we need is going to be very important. So I'm glad to see and hear your comments about that changing. And when I first joined this committee, I thought I was afraid of going back to a state-based exchange given an initial rollout, but it's been a number of years and a lot of states have been successful at that. So thank you for being supportive of that.
Thanks, Greg.
Well, any other questions? I guess I'll ask you a kind of a broad question. You mentioned lessons you've learned during the pandemic, and I know your team did a lot. We saw you frequently, and it was very reassuring to have you and your team on television and talking to people. Any other lessons you learned through that experience you might want to share with us?
Oh gosh, lots. I think we learned lots about what a modern public health system looks like and how far short of that I think we are, despite the fact the legislature has been willing to fund modernization. I think modernization was always a topic where you'd say the words public health modernization and a quarter of the room would nod off to sleep immediately. And I think now we've got a much better understanding of basic things like that those contact tracers that you put in Deschutes County to deal with sexually transmitted infections or hepatitis outbreaks or those kinds of things turn out to be super handy in a pandemic because you can pivot them to other work and you've built up an infrastructure at the local level to be able to do that and to build on. I've already talked about relationships with community-based organizations and others to do the work on the ground. I think we learned there is a degree of central capability we have to do. I'm really proud of the field operations unit that we have built that's gone out and had a huge role in closing the vaccination gap in communities of color in the state, where they go out and do testing events and vaccinations. They distribute food boxes. They set up camp at local community markets that serve populations that we're trying to target. It's really hard retail work that they do every single day. And that's work that I think will be hugely valuable in things like influenza and trying to close some of the gaps that we have in flu vaccines and some of those kinds of things. And again, just having that capability to go out in support of a CBO or a local public health authority and deliver those services. I think we also learned a lot about trust and a little bit about humility. I think we have often wanted to approach public health problems as experts, and that's certainly true. The amount of expertise and talent in the Oregon Health Authority and in local public health organizations is colossal. But you also need to trust people, and you need to trust people that, given the right information, by and large, they're going to do the right thing, and that can be challenging. I think there are times when we didn't do that. Best example I can think of is early on with masks. We were really afraid that on hearing that masks could be effective for slowing the spread of disease, people would go rush out and buy the medical masks that healthcare providers needed and couldn't get. And so we kind of wanted to soft pedal whether masks were effective or not. Or we were afraid that people, if they thought they could wear a mask, didn't need to socially distance. We were afraid they wouldn't, be able to walk and chew gum and do both things. And so, for several months, I think, myself included, we didn't say enough about the effectiveness of masks. And that left us, once we did start talking about it, open to being second guessed by a bunch of people who don't think masks are effective. And I think we learned a lot about how to be really careful about how we communicate information, how we share it, how quickly we share it. That I think is going to be valuable as we deal with other kinds of health threats going forward. Those are, Craig, three that come to mind. But certainly books will be written about what the lessons we've all learned have been.
I appreciate your candid comments. Ines, please.
This is Ines Kemper, and I'm new to this committee, so forgive me if this question has already been discussed in the past. Is Oregon at all entertaining the thought of universal health coverage?
Yeah, so there's a legislative committee, Senate Bill 770 committee, that has been working on recommendations for that issue. I would say we're sort of trying to eat the problem at both ends, if you will. The 770 committee is working on sort of the large scale proposals potentially for overall universal coverage. I'd say the work that we're all doing right here is coming at universal coverage sort of a segment at a time. I already talked about the fact that we've meaningfully increased in insurance coverage through expansion of the Oregon Health Plan during the pandemic. The Bridge Plan, I think, is a piece of that. The expansion of tax credits through the marketplace is a piece of that. And I guess the question policymakers will ultimately need to decide is the best way to get to universal coverage to throw out the existing systems and replace it with one bona fide universal system, or can you get to the same place as effectively or maybe more quickly by building those segments on top of each other, so you start squeezing that uninsured rate, as we have, from 6 or 7% down to 5 or 6%, down to 1 or 2%, and really meaningfully get to the same place. And I think we're really hitting it from both ends right now in terms of that.
Thanks, Ines. Any other questions for the director? Well, thank you, Pat. I appreciate your time. We know you're busy, but really appreciate your comments as well.
I appreciate the time, and if it's all right with you, I think I'll probably hang out here for a little bit and just listen in for a while.
Okay, thank you. So we're going to move to our next educational section. Great. All right, next up, we are going to have Leanne Johnson, sorry, doing the second educational series of this morning. It's the OHA's Equity and Inclusion Program. Welcome, Leanne.
Thank you so much. I appreciate the opportunity to be here, and it's interesting you call me Leon, because that is I was named after my great grandfather Leon, who on my mother's side was the first of my ancestors to have been born above the Mason-Dixon line. So there are many Lees, Leons, and Leannes in our family line based upon that legacy. So that was a nice connection to history and to legacy. So thank you. Good morning, everyone. I'm Leanne Johnson, Director of the Equity and Inclusion Division for the Oregon Health Authority, and it's a pleasure to be here. I'm going to be sharing some information about our programs. Oh, my pronouns are she, her, hers, I will say. And I identify as a Black woman with multiple disabilities. So thank you so much for this opportunity. And it's always a pleasure to follow Director Allen. And it's always a pleasure to be able to, the foundation that Director Allen puts in place for this work, because I can come in and just continue to amplify and don't have to do any corrections. So thank you, because there's times when that has happened in the past, but I very much appreciate the leadership of Director Allen related to equity work and related to anti-racism work, and the necessity of really focusing as upstream as possible to mitigate and to eliminate barriers in the system when it comes to equitable access, culturally responsive care, and the opportunity for all people in the state of Oregon for them to have optimal health. And it really does take a health equity approach for that, for us to meet our mission as a state when it comes to health systems transformation. And appreciate this partnership with all of you, and appreciate that that we have a chance to meet briefly. And please know that we are a resource. Our division is a resource to all of you. So thank you for the invitation. Next slide, please. So I wanted to give a bit of a background about who we are as an Equity and Inclusion Division, also known as the Office of Equity and Inclusion, or OEI. So you'll see those occur interchangeably, and we're all the same. So basically, from a foundation perspective, we do carry out 16 functions and more for the Oregon Health Authority and for the state of Oregon. And 8 of those functions are state or federally mandated. Our focus is really at a deep systems change level and a deep policy level to work once again upstream to dismantle barriers and to truly transform the system of health delivery. And I will also add that we do minimal direct service, so to speak. Our connection with the public and with community is vast. But our role there is not as much providing service as it is following the lead and the wisdom of community. So we, in our division, feel that our work, that our role, our positioning is to follow the lead of community. And Director Allen mentioned the humility in our agency that is growing and is necessary to do that, and who is around the table. And who are we not just listening to, but also how are we enacting the ideas and the necessities for change? So currently we do have well, actually our team is growing. There's a great update on this one point. For several years, we've had a team of 22 in our division, and due to very necessary and generous investment and also support from the leadership of the Oregon Health Authority, we're in the process of expanding our division to be more than 70 people, which is once again a necessity based upon the fact that the work of health equity and leading with health equity to achieve the mission, vision, and values of the Oregon Health Authority and health systems transformation, that our role is very critical in that. Next slide, please. So the next 2 slides here are just a listing of all of the programs and policy work that the Oregon Health Authority is doing, and that related to health equity. And these are the policies and programs that the Health Equity, the Equity and Inclusion Division is charged to lead and to develop. So some of these may be familiar and some may not. I'm happy to provide any, through a question and answer time, any information on any of these programs. But really, like for the first 2, for example, those are 2 programs where we really get at more culturally responsive care. That's where we get beyond access to insurance and get to the foundation of once you're into the system, how are you treated in that system, and how are we bridging the cultural gaps or the linguistic gaps? The next couple, Americans with Disabilities Act and Civil Rights, once again, those not once again, but those are very compliance based. And also a necessity, because we're still, I think, in this country struggling with just basic compliance when it comes to accessibility, universal accessibility, civil rights, and anti-oppression, anti-discrimination, and anti-harassment work. Race, ethnicity, language, disability, sexual orientation, and gender identity data collection standards. That's a growing program. Actually, the mandate has been in place since 2013, 2014, and it's really about how do we disaggregate data and understand the disparities and the inequities that truly exist that sometimes get masked, so to speak, when you aggregate at a very high level or aggregate at the level of the federal standards. So this work is around not only disaggregation, but also the opportunity for people to self-identify and see themselves, so to speak, in their data demographic choices. Equity advancement in the workplace. In the past, that we might have referred to that as affirmative action. And that doesn't mean we don't include that, because that also is a requirement. And those data are necessary to understand what's going on and who is experiencing barriers. So there's that work. We also have been leading a health equity metric for coordinated care organizations related to language access. Regional health equity coalitions are regionally based coalitions of people. This is where we follow. This is a very specific program where we're following the lead of community, where community is saying, these are the problems in our region and these are the solutions in our region. And our role is to support those solutions. Next slide. And here are a few others that I will, let's see, technical assistance, community engagement. We also are looking at policy and legislative concepts and making sure that that we're seeing that equity is integrated, health equity is integrated into that work at a policy level. So it's not only the idea of needing to advance policy that has not yet been written or adopted, but also we have to understand that that past policy has existing barriers as well. And so all of that work is critical to really understanding what needs to occur to transform our health system. Next slide, please. And Director Allen already spoke to this. Our primary goal, this is the goal of our agency, this is the goal of our division, and ultimately it's the goal of the state, since we as the Oregon Health Authority are leading health systems transformation for the state, and that is to eliminate health inequities in Oregon by 2030, which we arrived at through interaction with community partners throughout the state, and the barriers that were being identified through those interactions. Now, whether we do this or not remains to be seen. It's an ambitious goal. I think what's really, from my perspective, what's really critical about this is that it sets the intention. It sets the intention day in and day out for the work that we're doing from the standpoint of policy, practice, program. So we need to, as a result of this being our goal, it forces us, if nothing else, to ask every day, every decision, every allocation, is this detrimental to achieving health equity? Is it neutral, or is it forwarding? And if it's detrimental or neutral, we need to look at what we're doing. We need to look at doing something different, because we need to be proactive, active, and taking affirmative steps towards eliminating health inequities. So this really does set an intention, and quite frankly, creates a lot of stress. And that stress is necessary given the urgency of this matter, and given the fact that people are experiencing ill health all the way up to losing their lives early in their lifespan because of those inequities that exist. Next slide, please. And just to give you an example of why we say, of why we go upstream, and why there's a deliberate use of the term health inequities. We do say disparities when relating to perhaps the data we see on, in reports and paper, those gaps that are reported through data. But what we're really needing to address are the inequities in the system. And this is where the Oregon Health Authority has chosen to go way upstream in this work to really look at those differences in health outcomes that are unjust, that are a result of social injustice, that are the result of 530 years of colonization of lands and people, and that make some groups of people more vulnerable to poor health than other groups of people. And that's systemic. That is not around whether someone chooses to eat a Snickers candy bar or an apple. The health inequities point back to our long-standing legacy of injustice and colonization in this country, and that's a 530-year legacy. And one of the examples, which is very poignant, is that babies born to Black people are more likely to die in their first year than babies born to white people. And this remains true even when we adjust or control for income and education. And so this is not always a poverty issue. It's often not a poverty issue. It's often may not be an access issue. It is the inequity and the injustice and the oppression and the racism that is built into the system. And so research has shown that there's a link, for example, between racism, toxic stress, and health outcomes for babies and for people who give birth to babies. And that is avoidable, and it's rooted in social injustice. So we are going way upstream in this work. Next slide, please. And these are some of the assumptions and values that we move, by which we move forward our work. I'm seeing that's kind of jumbled, and I'm sorry about that on this slide. But really, the focus here is that we are focusing on that which is unjust and unfair, and that which quite frankly has targeted groups of populations of people. And one of those outcomes of that targeting is inequitable health outcomes and health gaps. And so also taking this beyond just whether one is free of disease or not, taking this to a sense of well-being, all the way to the behavioral health functions and work that's being done by our agency. Just understanding that the assumptions and values are at a very, very foundational level, and understanding the touch points in multiple systems that create poor health for people in our state and in our country. Next slide, please. And Director Allen also helped provide a really strong foundation for this work related to our health equity definition. This was adopted in 2019. And there are a variety of aspects of this that are critical. Every word has been chosen very carefully. This was done via our Health Equity Committee that reports to the Oregon Health Policy Board, and was adopted by the Oregon Health Policy Board, not only for their work, but for the overall Oregon Health Authority. And looking at this, really critical pieces that we're talking about health and well-being. We're talking about populations of people that are disadvantaged because of oppression, that long-standing legacy, and because of racism and social injustice, and that is a key point in this work. And then looking at what some of the solutions are. There's action that's inherent in this definition, on that ongoing collaboration, that humility, that who's around the table, that and the working with community partners, and very importantly, also tribal governments, and understanding and respecting the sovereign nation status of tribal governments of the 9 federally recognized tribes in our state. Director Allen pointed to the equitable distribution and redistribution of resources and power. Once again, when we go back to when we talk about health inequities and what is to counter that, we've got to recognize, reconcile, and rectify both historical and contemporary injustice that interfere with the well-being and the good health of all people in the state of Oregon. Next slide. Okay, that's it. So I ask if if we have time, I'm happy to provide additional insights, questions, feedback, pushback, whatever you may have. Happy to engage in that.
Thank you, Leanne. We do have time, so if you have questions and you're online, please raise your hand, or anybody in the room. Leanne, this is Craig. I have a question for you.
Yes, thank you.
I appreciate the overview. That was excellent. I'm curious how you think we could incorporate this work in what we're doing on the committee. Do you have some thoughts about that?
Yes, and actually have already had some great interactions with Cheeky and other colleagues in the program, the Health Insurance Marketplace. And I think that one of the conversations we've been having is how do we take the premise and the values and continue to integrate that into marketplace work as well, because when we talk about inequities, especially when we say inequities are not always an issue of poverty, but one of access, yes, and then what the experience is in the system after that access occurs. Is it culturally responsive care? Is it care that is free of barriers? Is it care that is free of oppression and racism? I think that when we talk about the opportunity for access to health insurance for all people in the state, universal access, that there are some basic foundations to that kind of run across the human spectrum, where no matter where you're getting your insurance from. And so I think that as I said, we're here as a resource, looking forward to being of service to the program, and you all as an advisory board as well, I think are key in providing that connection to those that you are of service to and those of us who are to be of service. So I'm just hoping that we can keep in communication and hoping that we can assist in any way to embed these principles in all aspects of health and health insurance delivery. It's a little more philosophical than practical and tangible. That's where it comes to my mind.
Thank you for that.
Thank you.
Any questions? Leanne, comments? Well, we appreciate your time this morning.
Thank you.
And thank you for the excellent presentation.
Oh, thank you. Appreciate that. Good luck, and I'm here. Our team is here if you need us. All right.
Yeah,
thank you so much.
Look forward to seeing you again.
Take care. Alrighty. Bye-bye.
Thank you. All right. So we're still a bit ahead of schedule, and next on our agenda is a Medicaid redetermination update from Vivian Levy. She's here. Welcome, and take it away.
Thank you so much. Hi, everyone. My name is Vivian Levy. I am the Eligibility Policy Business Director for the Oregon Health Authority, and very happy to be here today to talk to you about what we know around the public health emergency unwinding and the redetermination process, and answer whatever questions I can. So if we could go to the first slide. So I'm sure all of you are very familiar with this, but just to give very quick background, of course, throughout the pandemic, we have been keeping OHP members continuously covered. Once a person becomes eligible, they've remained eligible. And as we've done this, it's gotten to us to a place where we have over 1.4 million people currently receiving Oregon Health Plan. When the public health emergency ends, we will get notice, which we'll talk about in a few minutes, and we will have 14 months after the month in which it ends to complete the whole what we call the unwinding process, which is really the process of redetermining everyone who's currently receiving benefits, and finding out whether or not they are still eligible. And if they are still eligible, ensuring that that coverage continues, and if they're not, helping them transition. So we have to initiate that process and give people enough time to respond, and then allow enough time for people who are no longer eligible to close. And so that means that we really have 10 months to take the number of people would usually redetermine in a whole year and redetermine them in 10 months so that we can complete that whole process. So when the PHE ends, which we don't yet know when that will be, that's what will kick off that 14-month timeframe. We can go to the next slide. So we have three kind of primary goals with our public health emergency unwinding process and all of these different things that we're trying to put in place. The first is to make sure that people who are eligible for Oregon Health Plan stay enrolled in Oregon Health Plan, and that we set up a process and provide as much support as possible throughout that process to ensure that we are not losing eligible people because our processes are difficult to navigate and present barriers. So that's the number one, the number one goal. The number two goal is that for those who are not eligible for Oregon Health Plan anymore because they've gone over income, etc., we want to make sure that they have a supported process to transition into whatever their other insurance options are. The goal overall is to make sure that as many people are insured at the end of the public health emergency unwinding as are currently insured, if not more. And so that involves not just making sure that people eligible for OHP stay eligible, but also making sure that we have a framework in place and supports in place so that people have access to other coverage if they're not eligible anymore. And then the kind of what I think of as the underpinning of all of this, the thing that's necessary in order to make both of these other things happen, is that we empower and support the people and organizations out there in the communities who communicate with our members, who help our members apply, who help our members report changes, and that we make sure that they're empowered with the information about what's happening and that they have the tools they need and the information that they need to help people navigate through this process. So those are the things that if we can do all three of these things, I will consider us to have been successful in this unwinding process. Next slide, please. So here's what we know, because what we don't know is when the public health emergency is going to end. What we do know is that it has just been extended for another 90 days on July 15th. They, came in just by the skin of their teeth about 4 days before it was supposed to end and officially announced that. So the soonest date when the PHE could expire at this point is October 15th. That's the earliest when it could happen. And if it happens on October 15th, then November becomes month one of that 14-month process that I just described. States will be given 60 days advance notice before the PHE ends. So if you're following the very complicated bouncing ball here, that means that by August 15th, we should know whether or not the PHE is going to end on October 15th, because we've been told that we'll be given 60 days advance notice. So if we get to that 61st day and they haven't told us, then our assumption is it's going to get bumped out again, which in this case would be to January. And I will share with you that I think it's likely that it is quite likely that it's going to get pushed out again until at least early 2023. But that's the information that we have for now. And so we're doing everything that we possibly can to get everything ready and in place, anticipating that it could end as early as October, but also trying to take advantage of every additional month that we can to get more prepared, to talk with more folks like you about what it is that we need to be doing to be more effective, and really trying to use this additional time to our advantage to set up the best process that we can. Next slide, please. So one of the things that we have been given flexibility by our federal partner CMS to do, and we are taking full advantage of, is to take our entire eligible population and think about how do we spread them out over these 14 months or over these 10 months so that we can provide, so that we can meet all of those goals that I described before, so that we can keep people eligible, give people enough time to transition, make sure that our support organizations and systems that we have in place are not overtaxed by any particular time period. And so what we've done is we had kind of a group come together across Oregon Health Authority and Oregon Department of Human Services and talk about populations who may need additional support getting through the process. As well as populations who may need less support getting through the process because, for example, they're already assumed eligible for Medicaid. So we kind of went through and reviewed these populations. And just to give you some examples, people who are receiving long-term care services and supports, those cases need additional touch, additional resources to move them forward by case managers. And so we wanted to make sure that in no particular month did we have a huge influx of these cases coming up for renewal so that we overload our case managers and we're not able to actually give people the support that we want. So we took that population and spread it out fairly evenly over the 10 months so that we're going to be able to provide that support in a more coordinated way. People with no permanent address, we want to push a little bit further down into the later part of the redetermination process so that we have as much time as possible to make sure that we have the right address information for them, that we can contact them, that they're not being closed simply because we don't know where they are. So those are just a few examples. We have already done the work in our eligibility system to kind of identify all these different populations, but there's still room to have a conversation and to get input for the next couple of months in terms of how these populations will be sequenced over that period of time. You know, if there are certain people who maybe should be redetermined earlier or later in the process, that kind of thing. So that's one of the things that we have done to try to make sure that we can be as effective as possible and support people as much as we can. And also not overload our call center or our community partners as they're trying to provide people with help. Next slide, please. So I just have a couple more slides and then I'll open up for questions. System and process changes to support people. So these are just a few things that we are trying to put in place so that the unwinding process is successful and also so that people are more supported moving forward. So one of the things that we know that's a huge pain point is the process that people had to go through to report address changes. If they, if they called to do that, they could be on hold for a very long time, or their community partner could be on hold for a very long time. And if they tried to use our applicant portal, our self-service portal to do that, they had to go through a whole change reporting process, which is basically like going through your whole application and get a new eligibility determination. And that was a real barrier for folks. So we've added functionality to the applicant portal, to the dashboard that you come to right when you log in, so that you can actually click on something on the dashboard and report changes to your contact information that way. And you don't have to go through the whole eligibility process to do that. So we're hoping that that is going to make things quicker and easier for our members, for our community partners, so that they don't have to spend their valuable time sitting on a call that might get dropped to report that kind of information. They can just very quickly do that, like you'd be able to report that information to the Postal Service, for example. Another thing that we have done that we haven't been able to do in the past, but our federal partners have given us more flexibility right now, so we're taking advantage of it, is to allow CCOs to report address changes on behalf of members. We have never been able to do that in the past, but there are some administrative barriers that have been lifted. And so we're working right now with the CCOs, with KEPRO, with Care Oregon, to put together a process so that they can get those address updates from their members and then report them to us through an easy method, a secure method. And then we are contracting with an organization that will be making those updates directly in the one system. And so that I think is going to be another key to making sure that we're meeting people where they're at, that we're not sending them to multiple different places when they have something to report, and really kind of facilitating that process so that CCOs aren't feeling like they have more accurate information than we have, which is not a good position to be in. So, and then the last thing that I'll share, we're doing more than this, but I wanted to highlight a couple of things, is making sure that there's extra time to respond when we send a renewal and additional time before we close someone. So in the past, when we would send a renewal and we needed verification, we'd usually give people about 30 days to provide that. We are extending that in the PHE unwinding period to 90 days. So when we ask people to provide us with income verification or verification of anything that is needed to complete the renewal process, they'll have 90 days to get us that information. We'll be sending reminder notices to people who have not responded after 30 days and after 60 days. Just as a, people have lots of things going on in their lives, and just to remind them that this request is out there. And then when we actually close someone, we are going to be giving them 60 days advance notice. And this is for two reasons. If they're truly not eligible anymore, that gives them an extended time period to make sure that they are enrolled in other coverage before we close out their OHP. And if they were closed because they simply didn't complete the process for whatever reason, if they come back to us within that 60 days, we can restore them with no gap in coverage. So we want to make sure that we're creating as much of a runway for that as possible. Next slide, please. All right, I think this is my last one. So member experience during the public health emergency unwinding. This really just kind of describes what I was just saying, which is that for a person, let's say a person who is part of the group that's going to go through a renewal in month 1, they'll get their renewal packet in month 1. It might be an automated renewal and nothing needs to be done. It might be an automated renewal, but they still have to provide income verification or something like that. Or it might be what we call an active renewal, which is that packet that you actually have to review and sign and send back. So folks will have 90 days to return any of that information. And then at the end of month 3, if they still have not returned it, that's when we would send a closure notice saying you will be closed at the end of the month, in 60 days, and giving them some information about what they can do. So that's the process that folks will go through, and we'll continue that process in a cycle 10 times until we get through everybody who's currently receiving OHP. If a person reports a change before they come up for renewal, let's say that the public health emergency ends in January, and they're up for renewal in August, and their income increases in March, and they call us, we will take that change that they've reported, but they will not lose coverage until they have gone through a full renewal. So they will retain that protection until they are actually up for a full renewal. Next slide, please. All right, we're at the end. So now I'd love to know what questions, comments, thoughts you all have.
Ron, please.
Thank you for the presentation. There's a lot of really good information here. You talked about in groups releasing renewal requests, etc. Is there any thought to like a region, like if one particular county or two counties get overwhelmed by a number of renewals where the community partners they're not enough or they're going to be too busy. Does that make sense? Is there any kind of a regional type of release of renewal requests?
Well, what we have the ability to do, we've set up a really flexible kind of framework for restructuring renewals. So if we get 2 months into the process and we realize that there was something that we didn't account for, or there's a particular area that's overwhelmed, we have the flexibility, even once we're in that process, to move things around and to move cases around. And so so we'll be able to kind of respond to spikes like that as we go through the process.
Thank you.
Of course.
Vivian, this is Lindsay. I question about that. It does sound like OHA set up a really flexible redetermination plan. That sounds really great. I'm curious if community members or community partners are able to request any of that flexibility. Like, let's say we have a client who is up for redetermination in February, but whatever, they've got life stuff, and it would be really helpful to have them be redetermined in July or something like that. Is that something that
we don't have the ability to do that on an individual case level? But what I would say is that in that situation, I think, one of the things that we are planning to do, I talked about sending those 30-day and 60-day notices if people haven't responded. We're also planning to create reports for anyone who has a community partner, and we'll do this for any CCOs that want it as well, so that we're sending out, here's all the people who received a notice because they didn't respond to us after 30 days. And then that will empower those community partners to be able to do some additional extra outreach to those targeted folks that have not actually responded and give them some extra help. So we will be incorporating that into the process.
That's very cool. Thank you. And my other question is, I've talked to a lot of people on OHP who have become over income or significantly over income for OHP, and some have said, I want to be off of this, but for a while we were being told that we couldn't let people just elect to drop and get onto a marketplace plan and get tax credits. And so I'm curious what's being done about the people who are really high income and still on OHP. Are they being fit into those, what did you call them, like the higher risk and lower risk categories regardless of income?
That's a great question. So one of the things that I didn't get into because I wanted to focus our time today, but I do think in retrospect it's important to mention, is that one of the other things that we are doing in our spare time here is building a temporary Medicaid group for people up to 200% of the federal poverty level. And so people who are redetermined and fall between adults, I should say specifically, adults who don't have other coverage, who are redetermined and fall over the income limit, but under 200%, will actually remain covered through this new temporary Medicaid program. So that's one piece of that. And so that population, we're actually delaying until later in the redetermination process, only because we're getting more federal match for them right now than we will be later. And so it's just advantageous to the state to do it that way. In terms of people who are above 200%, currently they are spread out over the months to allow for support from insurance agents and other folks to help them actually get connected to the marketplace. So they're not in any one specific spot. They're spread out across the overall time period. So that's how it's set up right now.
Okay, and then my last question for you is around people who do want to report a change and do want to get off the Oregon Health Plan. Do they just come and report their update and then elect to drop?
They can a person can request to voluntarily terminate their coverage at any time. The hiccup here, and I can talk a little bit more with Chicky about this, and we could probably give you some more information in the next meeting. But the challenge is that sometimes the marketplace will ask people for a letter saying that they're not eligible for coverage for Medicaid coverage anymore. And that's not the case. So we can't produce a notice that says they're not eligible anymore. We can absolutely give them a notice saying that their coverage is closed whenever they ask us to. So I'll talk with Chicky a little bit about that and see. It may be that we can talk to our marketplace partners and find out how they're handling that right now.
I know it's been a bit back and forth with that one. So
Yeah. I think it's kind of inconsistent. So
yeah. Thank you so much.
Of course.
The first part of her question, though, was that often if they're become eligible for an employer plan? Was that the first part of it? If they become eligible for an employer plan, they can voluntarily drop OHP, is what I think you had just said. But the situation I've run into a few times is that somebody is on OHP and wants to go on to an individual medical insurance plan, and I've been telling them, if you unless you get a termination notice from OHP, there really isn't an open enrollment eligibility for you to go on to an individual plan mid-year, especially if you're eligible through the marketplace, through healthcare.gov. You're not being termed, you're voluntarily terming. So the letter you mentioned, that coverage is closing, probably isn't going to suffice for the marketplace.
Yes. I think that's probably correct. That's where I was saying I'll loop back with Chicky, because I do know that we've had some conversations with our marketplace folks about this exact scenario. And I'd like to know if there are any changes in how they're going to be handling it. But you're right, that is my current understanding, is that because the notice that we provide is a termination notice, but it is not it's a closure notice, but it is not a notice that says they're not eligible anymore. It's not sufficient for that purpose.
Thank you.
Of course.
So just wanted to piggyback on what Vivian is saying. Is actually at this time, healthcare.gov is allowing for self-attestation, that they are no longer, that they've closed their OHP coverage. Moving forward, we need to verify if that will still be the case. But as Vivian said, we need to coordinate further in terms of what we can and cannot do and what healthcare.gov will or will not require moving forward, especially as the PHE will start unwinding. So more details for sure to come your way, ideally by the October 13th HIMAC meeting.
Thank you.
Looks like there's a comment from Cable. You want to read that?
It just looks like Cable has some information he can share as part of that conversation too, so that's great.
Are there any other questions for Vivian? Paul, please.
So, thanks, Vivian. This is Paul. I assume more time is always better for the PHE ending. Within that, though, is there a certain time of year that would either resource-wise or just the nature of the flow of that population that would increase our odds of executing this well? Like the January popped into my head as either possibly really good or really bad as a transition point.
I think that's exactly right. Yes, we have absolutely thought about that, and I would say that honestly, January would be very, very challenging, and that's why I think it's probably unlikely. I think it's likely that it will get pushed out even more than that. Obviously, it is in the middle of open enrollment, and it is also in the middle of the holiday season at a time when almost every state is resource constrained, has workforce issues, etc. And so I think that I think January would be a challenging time for those reasons, and we would probably choose to have a smaller number of renewals in those first couple of months to account for that and to kind of balance that out. I think that, one of the things that we're trying to think about as much as possible, we've heard a lot from states that aligning Medicaid and SNAP redeterminations, for example, increases the likelihood that people will respond to their Medicaid determinations. So we're trying to work with the other programs as well to make sure that we're thinking about what are high months for SNAP redeterminations, for example, and can we kind of ride on those coattails to make sure that we get higher numbers. So I don't know if there's a magical month when you know, our magical time period when we'd be more likely to be successful, but I do know that I'm hoping it doesn't happen right after the holidays, but if it does, we will make it work.
Thank you.
Any other questions for Vivian? I have a question for you. This is Craig. Thank you, Vivian, for the presentation. And I think the follow-up presentation we have too will help kind of fill in the gaps for everyone as well. So we're just to try to frame this, we have to go through the redetermination process for the 1.4 million Oregonians. That's regardless. Maybe some of the options they have are up in the air at this point with the Ridge Plan, that work being done. But we will go through this process. And I think I get from the member experience how you're thinking about it from Medicaid's point of view and the CCOs. I'm wondering how you're working with the marketplace or carriers on, is there any coordination that's happening there? And maybe that's where the community and partner work groups addressing that. Maybe you can just talk a little bit about outside of the Medicaid scope, how you're
Absolutely.
What you're doing there.
Yeah, I'll share a little bit, and then I'll also ask Chicky to speak a little bit to that. What I will say is that I think that there's a very encouraging understanding that we haven't necessarily always seen before, a cooperation that's happening between CMS and the marketplace. And part of that is CMS has provided a lot of guidance around the flexibilities that, for example, qualified health plans have for reaching out to people during this redetermination timeframe, what information they can provide, how they can participate in the process. And so we have been, we're very excited that our marketplace folks are part of Oregon Health Authority now, because it really allows us to facilitate a lot more coordination and collaboration, so that they've been included in our in a lot of our planning and a lot of our design, and really making sure that we're aware of each other's work and tied into each other's work, so that the plans are aware of what's happening and can get engaged as well. So that's what I would say, and I'd love it if you have anything you'd like to add, Chicky.
Yes, happy to jump in. So Chicky Flowers, administrator for the marketplace. So as we all know, we're in healthcare.gov. So there are limitations to what we can and cannot do, because we do not have access to the system that healthcare.gov uses. So however, as Vivian said, we are fortunate enough to be part of the Oregon Health Authority now. So collaboration is a lot easier, and exchange of information will be hopefully easier to do. And will it be seamless? Most likely not. Nothing really is seamless when it comes to data transfers. So one of the few things that we are hoping to do is first off, once Vivian and her team and the One System do the redeterminations, we will get a file for those who are no longer eligible for the Oregon Health Plan, and most likely will be eligible for the marketplace. We'll take that information and then do targeted outreach and education and enrollment assistance. Once the PhD starts unwinding, we will have a call center where these no longer eligible for Oregon Health Plan folks can get access to. They can call this call center and really ask for services in terms of, hey, can you help me find the nearest community partner or insurance agent that I can work with to find a marketplace plan. So one call center is a part of the services that we will be providing. Another will be, of course, hey, for example, Don Shaw calls the call center, or at least works with the marketplace team. Hey, Don, it looks like you're in Marion County, and it looks like in this area, the second lowest cost silver plan will be X, could be X, and here are other plans that might work for you. Another strategy that we are looking into is hopefully being able to repurpose the CCO 2.0 algorithm that will eventually, this is a goal, We haven't quite gotten there yet, but the hope is we'll be able to use this algorithm to find the plans, the plan, or rather the providers that Dawn used in the Oregon Health Plan, and mapping that over to, hey, which qualified health plan, which marketplace plan covers your most favorite providers. And so you have options, whether it's the cheapest plan in your area, which metal tiers might work best for you, and which plans will cover your providers. So we're hoping to at least provide you with as much information as we can as you move over from the Oregon Health Plan to the marketplace plan. And while also at the same time telling you, hey, these plans, these are your the premium tax credits that you could be eligible for, so that your marketplace plan hopefully will not be as expensive as the original ticket price. So these are still some things we are in the process of running our due diligence for, and hopefully we'll have more information by our October meeting, right around the time for open enrollment. Did I miss any details, Vivian? There's a lot of things we're coordinating on, but kind of that's high level. That's the strategy, that's the plan for now. We do have to do a whole lot of wraparound strategies because we're not on healthcare.gov. And of course, we're also still waiting on what healthcare.gov is going to tell us what they're going to do. So for example, are they going to accept self-attestation that I'm no longer eligible for Medicaid, or are they going to require specific notices? And also we need to figure out too what their call center will be doing, what advertising they will be doing, and supplement it here in Oregon.
Well, that's reassuring. I'm glad that work's going on. Look forward to hearing more about it.
Yes, definitely a lot of work going on. Keeping my fingers crossed that the PHC will not be unwound in October, because that, as you know, our open enrollment is November 1 through January 15th. Should that happen, please do send a lot of cookies our team's way. We will be working very feverishly to get as many Oregonians covered for 2023.
Good. All right, any other questions for Vivian before we move on? Looks like there are none, so thank you for that.
Thank you for having me.
Yeah, appreciate all the detail. It's great. And it was a good lead into our next agenda item, which is an update on the Bridge Program Task Force. And we have with us Timothy Sweeney, who's a policy analyst for the Oregon Health Authority, and our very own Lindsay Hopper, who's our HIMAC representative on the Bridge Program Task Force. So with that, I'll hand it over to both of you to give us an update.
Good morning. Thank you for having me, for having us. I'm excited to be able to give this update to y'all. My name is Tim Sweeney, and I'm a policy analyst with the Office of Health Policy, which is in the Health Policy and Analytics Division, along with the Marketplace in OHA. And gonna try to do an update of the work of the Bridge Program Task Force that is developing this new coverage option for adults with income below twice the poverty level, but who aren't eligible for the Oregon Health Plan. And as was mentioned, Lindsay Hopper, who sits on the task force as a member of the HIMAC, will join and provide, I think, a lot more insight into the discussions of the task force and sort of the thinking of the task force itself. So as is shown here, I want to provide a reminder of what the charge is, what the task force was created to do, a high-level recap of their discussion topics so far and some of the decisions that they've made, some information about what some of their next steps are, where there's going to be some more information brought to the task force in their effort to develop the report to the legislature, and then some specific content around the most recent task force meeting that talked about the impact to the marketplace and some of the ideas for mitigating any potential negative impact. But before I go any further, I also want to just stop and offer Lindsay a minute to have any opening remarks as well.
Thank you. I'll be quick and looking forward to sharing this update with you, and thanks for presenting the slides up on the screen. Just kind of a quick note that there are many facets to this bridge program work, and I know there are a variety of views on many different levers. So I'm looking forward to hearing from the HIMAC and will certainly do my best to represent your views going forward. I expect there to be a diversity of views. We have several task force meetings coming up, and then there'll be some more in the fall. So thank you in advance for your feedback.
Great. Okay, to dive into the content, the next slide has just, again, this reminder of what the charge is to the task force and the direction from House Bill 4035 for what this bridge program should do or should be. And the first goal of the legislation in the bridge program is prioritizing health equity. And then beyond that, it provides some both guidance and also some pretty specific decisions almost for the task force. The plan should minimize cost to enrollees. The vision is to provide coverage through CCOs in order to preserve the continuity of care and people's access to their existing providers, with a goal of having the benefit package, the covered services, be as close to Medicaid as possible. The legislation directs to maximize federal funding and limit the need for state funding, and envisions at least a two-phased approach. One phase being, and Vivian talked about this too, folks who are identified through the redeterminations process through OHP, identified as being in this income range, and that could be sort of this first phase of a bridge program, and phase two being sort of a more full, complete implementation that would bring new enrollees as well as folks from the marketplace. The bill also directs this middle bullet here, I didn't forget about it, directs the task force to consider whether there's an option to give folks in this income range the choice between a bridge program and their existing marketplace coverage. That idea has a lot of operational and other challenges, and so we'll talk about that in a second, but that was specifically mentioned by the bill. Before going into then what the task force has been working on, I don't know if Lindsay, if you have any thoughts to share on the sort of guiding principles for the task force's work.
Lots of early conversation, I think, as well around dental coverage. But I think if you keep going, I'll chime in. I think we're good to keep, unless others have questions at this point. Thank you.
Great. So within this framework, the next slide starts to highlight, what the task force has been working on. And so I think I think the cadence has made a lot of sense. It really started with an examination of what the charge is, thinking through the legislative goals and the task force getting to weigh in on sort of their priorities and vision for what this was going to be. Staff provided, and we're working with a consultant team from Manat Health, information on the various federal pathways towards getting financial help for this program, and then really started to dive into to more specifics around plan design options. What should this program look like in more detail? What might the impact on the existing market be? What is the potential funding? Does the federal funding we get, would it be enough to implement this program with limited or no state dollars and with limited enrollee costs? And then last week, July 12th, really started to dive into the market impact conversation a little bit more. And then over the course of the rest of the year, there will be more plan design and more conversations about the impact on the market. And this is really all on track towards an initial report to the legislature September 1st with some plan design recommendations and some overall background information, and more work in the fall to inform a final report in November. All right, next slide will then land a little bit as to what decisions have been made and what some of these discussions are. And really, I think the first and maybe the biggest decision so far has come partly as a result of CMS direction, in addition to task force conversations about these various pathways to federal funding. The bill essentially told OHA and the task force to look at a 1332 waiver as a possibility, an 1115 waiver to use Medicaid as a possibility, or a Section 1331 basic health program as potential pathways to implement this program. With conversations with CMS, they have essentially said that other than Medicaid, other than the Medicaid expansion between the 1331 and 1332, they said a basic health program is the ideal pathway, in large part because of some operational issues doing this on the healthcare.gov platform, and in particular, some of the challenges associated with this idea to have to enable consumers to choose between marketplace plans and a bridge program. This choice of the basic health program does kind of take that optionality, that choice off the table in the short term, though the task force has been clear that they don't think that they've made that decision for the long run, and that they would like more conversation about that in the future. Next, they made some decisions around or made some directions around plan design and are providing staff great feedback about how to prioritize the structure of the plan, and in particular, how to prioritize different elements if financial feasibility becomes a challenge. And the elements that in particular have been talked with them about are covered services, what kind of enrollee costs are acceptable or not, and what type of payment rates to the CCOs would be acceptable. And this has also helped us sort of figure out what the next steps are to do, like what additional information is needed to help the task force make future decisions. And so one of those is some more discussion around the different services package between commercial coverage and the Oregon Health Plan, additional analysis about the population of people who will be covered and what we think they will cost. And as part of that, there's been a data call from DCBS to the carriers to provide a great deal more information to help produce some overall financial analysis to build on some of the initial feasibility analysis that was done to sort of decide whether this was possible, whether we could indeed do a program like this within the federal funding allowed. And I sort of skipped over this, but one of the findings of that first feasibility analysis is through the BHP formula, depending on whether ARPA exists or not, potential funding could be about $500 to $600 per member per month. And then the next conversation is what does that enable the state to deliver through this program? And with that, I mean, this has been so far the trying to distill the task force conversations over a course of like 5-6 meetings into a couple minutes is I'm certain I've left a lot out. So I think this would be a great time, Lindsay, if there's more context you would like to add.
You're doing a great job. We're meeting about every other week, so that this is a fast clip. There's a lot of content, and quite a bit has happened since this committee last met. I guess just maybe a few things I would add. We're going to talk more about financing in your next slides, but I think this is scenario planning on a broad scale. There are many things we would like certainty about, we would like to know more about, we just don't have it. We had a presentation earlier about timing of extensions and credits and all of the information you need to really assess viability and impact on the marketplace. So this is challenging for those seeking certainty in the short term. So a lot of this is, if the picture looks like this, we're building potential recommendations that look like that, and then some pivoting that could be allowed. To understand, I think, how the BHP could be helpful for Oregonians and appropriate in terms of its impacts on the marketplace, we really have to understand three groups of people. One group would be folks who are currently totally uninsured, not participating in OHP, not enrolled in a plan. That's one group. We need to know who would perhaps have to switch out of a marketplace plan. The timing for that is really important. Seems critical that not happen in the middle of a year, in the middle of filed rates, and that could be disruptive if not managed. And then, of course, those who would be transitioning from OHP. So learning more about all three groups, their health status, the timing, all of these pieces come together, and it's fairly difficult to juggle. And so a lot of our work has really been about understanding all of those components and what's available on the federal level. Anything you think I should have called out there, Tim, that I didn't?
No, I think that's great. I mean, that is, I think one of the, to underscore in particular the challenges on the OHP data side is that, the number of people who would move likely from the Oregon Health Plan to this BHP represents a relatively small share of the people on the Oregon Health Plan, and the even in the expansion population, and trying to better understand how that population, the health needs of that population and the potential costs to cover that population compared to the overall population that we have more complete data on is certainly a challenge. But like Lindsay said, it's kind of central to refining some of these estimates of the costs of the program.
And I think, all of those impact implementation and how people feel about the likelihood that a CCO could implement one of the options presented. What's the timeline that the federal government would require? So there's just a lot here, but we have some really important deliverables coming up that I hope will help us understand which options seem viable and best in service of many constituent groups. So happy to talk more about any of the waivers or the pros and cons of optionality and that timeline, but it's not something on the table in the short term, as Tim said. So I think that's all I would add, unless there are other questions here. Thanks.
Okay, now to the next slide. It provides a little bit more information about what some of these next bits of analysis are. As was mentioned, we had this first round, this feasibility analysis to sort of determine, is this worth continuing to look at? First blush, does this look like it passes the sniff test? And we think it does. And so there's this big data call from DCBS that's going to help give us a lot more information, give our actuarial partners a lot more information to assess the potential revenues and costs. And then there's some ongoing work at the OHA side and with the OHA actuarial team as well to sort of look more specifically at what we know from the OHP population to see how to use this data to again further refine some of the estimates, and this information will get presented to the task force in the fall. On the next slide, now we get into some of the conversations that we've just had on mitigating the impact to the marketplace, and I think it's clear that the task force is very concerned that we're not creating a new program that serves some people, but that the impact is more negative for others, and making sure that together it's still broadly beneficial. And so this is all a very complicated conversation, and the task force members I think have a wide variety of experience. So last week, Numi Lee Griffith from DCBS gave a really thorough sort of overview about kind of how the ACA subsidy structure works, how we're have gotten to the point where we've got to now. Silver loading and the dynamics there, what this means for CSR plans, the impact of pulling this 138 to 200% population out of the marketplace and onto a BHP, and how that changes the subsidy calculator information for the folks who stay there, the impact of losing that silver loading because that population won't be there, you know, the compounded impact of the potential that enhanced subsidies from ARPA go away at close to the same time, or you know, one ahead of the other, and sort of how all of that fits together and what that does to the individual market, or what that could do to the individual market. More analysis is underway, so it was largely a conceptual conversation to really get the task force up to speed as to like what is happening here. And then the next slide sort of outlines some of the, at a very first glance, high level conversation about what might we think to do about this. And I think the big takeaway is that reducing the silver loading will create savings for the federal government at the expense of Oregon consumers. And what might we think we could do to sort of recapture that savings and keep it in the hands of the people who are purchasing coverage on the marketplace. So there was a discussion around the challenges of state wraparound subsidies, and also some of the ideas that the state could have to capture these federal savings and think about different ways to invest it in a way that gets back to consumers to offset some of the premium increases that we think might be likely, and the potential value of increased outreach and education, and especially given the timing of everything that Vivian talked about, of the changes and people having to switch plans maybe mid-year, maybe shortly after open enrollment, and how additional outreach can help there. With that, I'll stop again. This part of the conversation was really technical, and I think I would certainly welcome your thoughts some more here, Lindsay.
Thanks. I just think it bears significant emphasis that this could have far-reaching impacts to the marketplace. So this is something that the task force absolutely needs to better understand. Conversations are ongoing, as I understand it, with CMS, but you talked about the importance of balancing who you're helping with what unintended harm you might cause, and this issue presents that squarely. At the same time, Oregon didn't create the silver loading problem, so we're interested as well, I'm sure, as a group, about whether there is a legislative fix, what the timing of that might be, what other opportunities or issues that creates. So just from wearing a HIMAC hat, listening to the task force, this is front and center for many folks about just squarely whether the BHP is viable, if we cannot come up with viable options here. So it's really in the weeds, but it's very, very important. So I appreciate the presentations we've seen, and there's certainly more to come here. The timing is also critical.
And just to back up real fast, silver loading is to explain that real quick,
sorry,
in case anybody needs that. Yeah, I know. I'm sorry about that. So originally in the ACA, there were cost sharing reduction payments that were made to health plans to increase the value of the products, of silver products, for people under 250% of the poverty level. Those increases were mostly targeted at folks below 200% of the poverty level, and it was the plans had to deliver these additional benefits to people who picked silver plans, and that was the federal government's way of paying for it. The Trump administration stopped making those payments, and so states had to kind of figure out how to make sure that the plans still got paid to increase the benefit levels for these consumers. And Oregon, like a lot of other states, essentially loaded the costs of those cost sharing reductions into the silver premiums, as opposed to spreading them all across the gold, bronze, and silver premiums, because those were only available to people who picked silver plans. They put the cost into the silver plan. What that did is made subsidies more generous. And so for folks who were not, especially not getting these cost sharing reduction plans, their premium subsidy either went farther towards the purchase of a bronze plan or a gold plan. And so we've seen some level of behavior change of people sort of using that additional purchasing power in different ways. And so once we move the under 200% folks out of the marketplace, we can't really load this cost into the silver plans anymore. So what happens is the cost of the silver plan decreases, but also the cost or the value of the federal tax credit, which is based on the silver plan, also decreases. So folks who were buying silver plans might not notice much of a difference, but people who are buying gold and bronze plans will notice a big difference may notice a big difference in the cost of their plan. And the amount of this difference, whether we're talking $5 or $10 or $50 or $60, is going to be the subject of that additional analysis that was referenced previously, to really sort of see what to get a better handle on a more micro level what the impact is going to be for consumers and how we might expect consumers to change their behavior.
Hey, Tim and Lindsay, I think at this point we're going to stop the presentation part, but we do have some questions. I think I want to give at least a few minutes for questions from the committee. So, Ines, did you have something that you wanted to ask?
I had no idea what silver loading was for the first 10 minutes of the conversation.
Well, it's a critical issue, and because of it impacts the subsidies that consumers receive. So that's why this whole issue is something that we're watching very closely in the Bridge Task Force. But my understanding of this is in the two-step approach, I think, Lindsay, that you talked about, at least initially, there won't be a silver loading impact. It's more when we get to a permanent bridge plan. Is that accurate?
So the two-step approach really reflects the conversations at the task force level about, hey, folks, first phase coming out of OHP, second phase, broader eligibility to move into this. So that's the most recent update I've seen in terms of the phasing, and then the corresponding impacts. Tim, would you add anything there?
I wouldn't add anything. I would certainly only know enough to be dangerous, and that's the sort of thing I would defer to the experts at DCBS about how all of that will play out. But I think broadly the sentiment of the question is right, that the two-step means there shouldn't be significant market impact in year one because we're not taking anybody out of that market.
Thank you. Any questions for Tim and Lindsay? Paul.
So, thanks for the presentation. This is Paul Harmon. It's around timing, like just assuming the bridge plan issues are resolved in a way that enough people are happy, and this is what we're going to go forward with. Like, what are the odds that it's available when the big Medicaid redetermination happens? Like, I get it from a long-term point of view, but will this even be available for this short-term big one that's about to happen?
Great question, and I would be happy to clarify that. And this is partly connected to Vivian's presentation too. In the short term, when redeterminations start, that's when we will have the 1115 Medicaid waiver eligibility category to keep folks in this income range on the Oregon Health Plan if they're already there and identified during the redeterminations period as in this income range. During that time, anybody who's covered through the marketplace won't see their coverage change, and folks who are uninsured now would still be able to enroll through the marketplace. And then that Medicaid category would not go away until we're ready to stand up this basic health program, so that there wouldn't be any kind of gap or cliff where somebody's has to fall off and then get back on in another fashion.
Thank you.
Thank you. Well, unfortunately, I think I do need to wrap this section up on our agenda, but I want to say thank you to Lindsay and Tim for the presentation. Lindsay, particularly thank you for representing HIMAC. You have the ability to reach out to the committee if something comes up in the meantime, but just based on the timeline, I think our next meeting will coordinate well.
Yes. I wanted to just piggyback on that real quick, Craig. So you all received the cancellation notice of the listening sessions for tonight, but there is a Bridge Program Task Force meeting next Tuesday, and those who would like to provide public comment are more than welcome to. So if you look at this task force roadmap, you will see October through November will be the mitigation strategies proposal in relation to the marketplace. The HIMAC's next meeting is October 13th. If we don't have the information by then, it doesn't mean we can't have a separate meeting. So just please know this is not the only time. HIMAC meetings, the standard ones, are not the only times that we can meet. You can request for us to meet and to talk about the marketplace mitigation strategies separate from the Bridge Program Task Force meetings. So please know that is an avenue that is open to everybody in the HIMAC committee.
Thanks, Jackie.
And the timing could be great because the task force will meet on October 4th. So there will be good information prior to the next HIMAC meeting.
Okay, so you can expect to be on our agenda for October, sounds like.
Sounds great.
Okay, great. I also want to mention there's a separate work group, a community partner work group, and both Gladys and Nishoba are representing the HIMAC on that, on sort of filling in for each other. So thanks to both of you for that. And I did happen to watch the last Bridge Plan Task Force meeting, and I saw that Mary Beth also provided public comments. So there's a lot of people involved in our committee that are involved in this process. So thank you to all of you. Well, with that, I think we have a couple orders of business before we wrap things up. And the first order of business I'd like to talk about is the charter. And thank you for, that's a great graphic. So everybody should have received a charter for the committee. This is updated periodically from time to time. Hopefully people had a chance to review that. I'll open it up if there are any comments to the charter before I ask for a motion to approve. Any comments? I don't hear any. Is someone willing to motion to approve? Thank you, Gladys. Or sorry. Thank you, Ines. Great. We have a second. So in the room, we want to say.
All those in the room, please. Thank you. And for the charter, those in the virtual room.
Aye.
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 Thank you very much. And for the record, the charter, the baseline charter for the HIMAC, the Health Insurance Marketplace Advisory Committee is passed on July 21st, 2022.
Okay. Next order of business is the baseline work plan that was also provided. And it shows what we'll be working on as a committee over the next year. So any comments before we approve this work plan?
I do, Craig, sorry. So this is the baseline work plan. And just to clarify, this is what this could be our topics for the next 18 months, starting including this month. Could it grow? Absolutely. Could it lessen? Absolutely. But this is the baseline work plan for the next 18 months for this committee.
Thanks for that clarification. Yeah, I found this very helpful just to see what's upcoming. Maybe somebody who's virtual could move to approve.
This is Mary Beth. I'll move to approve the work plan.
Thank you, Mary Beth. Do I hear a second?
This is Lindsay. I'll give a second approval.
Thanks, Lindsay.
All those who vote aye in the virtual room for the baseline work plan?
Aye.
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 Thank you. And all those in the in-person room?
Aye.
Thank you, everybody. Committee, the baseline work plan for the next 18 months from July 2022 through December of 2023 is passed July 21st, 2022. Thank you very much for your review and for the speedy votes. Next slide, please. So just wanted to kind of quickly go through the main responsibilities for the chair and vice chair. It is the time of the year, it is the time of the terms rather, that we are in the lookout for our new chair and vice chair. And in front of you are some high level bullet points of the responsibilities and the tasks related to the chair and vice chair position. Please know that the staff and I, we do try to hand everything in a silver platter to make being the chair and vice chair as easy as possible. Is it seamless? It is never seamless, but we do try our best. So moving forward, if you would like to nominate someone, including yourself, please do email me your nominations. It's chicky.l.flowers@dhsoha.state.or.us. I hope you have my email by now. Please send me your nominations. I would love to have your nominations by the end of this month through the 31st of July. And I will take it from there by email in terms of next steps for the nominees. Of course, if you nominate someone, I have to check with the nominee if they would like to serve in that position or not, and then come forward with a final list of nominees at our October meeting, for which we will vote our next chair and vice chair for the completion of this term.
Great. Any questions about the process? Thank you, Chicky.
You're welcome.
All right, I think we're at the point where we'll open it up to public comment. Not hearing any public comment. We will get to the end of the meeting here. I just want to thank everyone for your time this morning. It was good to see people in person. Hopefully people will take advantage of that going forward. And thank you to all the presenters as well. There are a lot of good content this morning. And hope everybody has a great day, and we'll close the meeting.
Great. Thank you, everybody. HIMAC committee is officially closed.
Thank you, everybody.